diverse, different types of omics, different types of imaging data, digital endpoints, etc., etc. And so here, this afternoon session, we want to shed a bit of light on how this works and see a few examples. So I'm very happy to welcome Paul and Damien for the first talk. Paul is working at Roche as a statistician, and Damien in Sysnav. As I learned just before this session, that's a company focusing on navigation, and Paul is heading the healthcare department in there, where they apply these types of methods, well, to healthcare. I'm very curious to see how this works. Thank you.
Hi, and thank you for the opportunity to present this here. So I'm going to just start with a few motivation, and then Daniel will take it over for a bit more detail on this talk. So, but as we know, we have a new generation of clinical trials, and maybe focusing on the bottom row here, we want trials that are more inclusive and more diverse, more patient-centric, more decentralized, always cheaper and faster, and more real-world like trials. So something that's more generalizable to a real-world situation. And sometimes we're going to other application areas, rare disease, heterogeneous disease where effective treatment exists, and slow progressive disease or in a prevention setting. So all of this calls for a new generation of endpoints. And this is where the digital endpoints and digital health technology are very attractive and hold a lot of promises. So on purpose, I didn't want to show a slide that shows all the potential, marvelous thing that the digital endpoint can do, because I think we've all seen that. But practically, I think there's a real match between the intent and the generation of making clinical trials more patient-centric and easier for patients, and all this digital health technology in addition to all the things we already know. So the validation of digital endpoints, it's cool, but it's very difficult. It's complex and it's risky. And I wanted to emphasize here that there are guidances. It's not completely the Far West. You have FDA guidances, professional guidances, FDA, DIME, version 3, etc. But every time it's a new adventure. So there is no two pathways for developing an endpoint that's the same. So that makes it really, really complex. So for me, it's really coming from my experience was developing drugs, and I came to developing digital endpoint, and it really looks like these two pictures where drug development, you're on the rail, on the train, you know where it's going, it's phase 1, 2, 3, more or less. Developing digital endpoint is much, much more complex. And at the same time, the bar and the level of evidence that's required, it's very high, and it requires a lot of interdisciplinary engagement, coordination, motivation. And for this audience, I just wanted to say a little bit with respect to the title of this talk. It's a good place for statisticians from pharma industry to be, and it's a great opportunity to contribute, add lots of value, and be leaders in this field. And I just try to list here some of the quality or experience that we've developed as statisticians working on clinical projects that are really transferable and very valuable when we try to develop endpoints. And a lot around leadership, cross-functional communication, systems thinking, but also the deep understanding of data science and human core. That's all very useful. And this is really a good place for being influential and being strategic partner, even being leaders. So I'm trying to give a picture of a complex problem that requires a lot of rigorous thinking. Our statisticians are very well placed to play a key role. And the riskiness of it is probably fairly low probability of success. We've heard a lot of stories of things that look very cool, very promising, but at the end, you push it a few years and then it doesn't go anywhere. So you need a very strong and solid foundation, and that's measurement. So you need a very precise, very reliable measurement, so this whole thing comes on top, and then you still hold a small chance for success at the end. And this is where the partnership between Roche and Sysnav, the strategic partnership, come into play. So I think 2 years ago, Roche and CISNAV has formed a strategic partnership to develop new endpoint. The idea is to match the right technology with a very precise and reliable measurement with the right sort of clinical application and clinical expertise coming from Roche. And we've already seen the benefit and the reward from this sort of collaboration with first and only qualification as a primary endpoint of this variable called stride velocity 95 percentile, which is coming from a device that people put on their ankle. There's been a very recent development in addition to this, and press release came just last week, which was from a Sarepta study in Duchenne disease, where the primary endpoint was going in good direction but did not reach significant, but the SV95C endpoint, so the endpoint coming from the device, from the digital health technology, was significant. It was another sort of very nice illustration of the potential added value and power of this sort of technology, and I thought this was much more impactful than another kind of a fancy cartoon showing how we could do marvelous things. So we hope this is just the beginning, and this, this multi-year collaboration. We're going to tackle other disease and other type of endpoint, and I'm really happy to hand over to Damien to give you more of the details behind that story.
Thanks a lot. So I'll try first to describe a bit this SV95C, what it means exactly. So, and I think it means different things for different persons. Right? So if I'm putting myself in the shoe of the patients, what I do have is I'm wearing a wearable, so a small device, during the day and repetitively for several days. And then essentially this records very precisely what I'm doing with my upper body and lower body, or upper limbs and lower limbs. So that's really what the patient is seeing, is not much than that. He's just picking up a watch-like device every morning, putting it back on the docking station. And, we don't ask him to comply to any specific procedure, protocol, to do like things at home or anything. If I'm putting now in the shoes of a clinical operation team, what essentially they're trying to track is, to put in place the right procedure for training, for compliance check, for data management and so on. But in the end, everything is about trying to have the device record the real life of patients as close as possible in all the situations that the patients can see. Right? The battle is really to try to get what we call the compliance. So how many hours of recordings do we get as good as possible, right? So essentially the patient really wear the device in every life situations. Then there is a perspective that that is quite core to what we do in CISNAV, is really like trying to develop, so the biostatistician perspective, right? Is trying to develop out of the thousands of data points that comes every seconds, trying to develop one meaningful single outcome that would represent the patients. And this clinical outcome should be, of course, reflective of the, should be meaningful, should be reliable, and should be sensitive to, whether it's treatment benefits or whether it's disease progression. And so I think that's what we would care about in a good endpoint. And so that's, the framework in which we worked in this project, in developing, hardware, software, algorithm all together to reach this meaningfulness. Now, if I try to show you, so that's a little girl named Quincy who is equipped with the device, and I'll try to give you a bit of a perspective in terms of the data. What do we see? So you can see that, so this little girl is affected by Angelman syndrome, so she's walking in a bit of an unlike with ataxia, a pattern with ataxia. If I represent a leg with two segments, so the leg and the foot, here is what the data that we can see, right? So essentially, in real life, without needing the video on the left, which comes from the mom, this is on the right what we are able to reconstruct, right? So we reconstruct
the full steps, the size of the steps, when the precise times when they were making contact with the ground, how long, how fast were the steps, how high when we woke up on stairs, what type of patterns of the steps, and so on. Right? So the old questions was, okay, now that we have reduced maybe the thousands of points to, like 1 point per second, roughly, like one element on the steps, what should we do with these elements to make a robust endpoint? And what we've done is essentially, if you compound all of the endpoint, the steps, you only take the 5% faster steps. This is what we call the SV95C, so the velocity at which patients was performing the 5% faster steps. Then this endpoint is quite robust because it's not so much affected by your daily activity. So we know that if we record for long enough time, you will reach your top performance, and this top performance is not limited when you are patients by your activity, but it's really limited by your ability to go fast. And that's really like, so if we were to measure, numbers of steps per day or anything, this will not be meaningful, this will not be sensitive. But since, it's something that follows the top performance of the patients, then we are able to get meaningful information. Now, so that's a bit, the short of the fun story. Actually, the fun story started, 15 years ago now. So you need to develop the full stack. You need to develop a device that is precise enough, and you will see a bit why afterwards, right? You need to then design, these clinical endpoints, so to try to have the idea of measuring top performance, then to try to understand what top performance means and so on. So, and then you need to go to the regulators and say, hey, Mr. or Mrs. Regulator, we think this is the right one. We've done those type of validation. Do you agree with that the validation is complete? And do you agree that this would be a good endpoint to measure the efficacy of treatment? Right? And that's essentially, I put that as steps that do not happen in parallel, but in fact, we had a lot of things that went into in parallel. I'm just going to try to paint you a few, a few ideas of things that went wrong or things that could have went wrong or gone wrong. Sorry. Just to paint a bit of a picture there, and then I'm happy to have a bit of an interaction, a bit more live interaction on this qualification, because we qualified SV95C as a secondary endpoint in 2018 and as a primary endpoint mid 2023. So I'm happy to describe a bit more, what the process was like and take your question on that, right? So. And that's not a political picture, sorry for that, but that's really the saying, we have a minefield in front of us, so any steps we do in each direction, we have the impression that this could be a minefield. And the first one is one that is close to my heart, which is the analytical validation. So again, I've shown you that it was important to have verification, analytical validation, clinical validation, and then going to the regulators for regulatory approval. Analytical validation seems the most obvious one and the most simple one. What does it mean? It means that my device is measuring what I'm asking the device to measure in the patient population that I'm looking at. So in more or less one of the statements that we had is our device measures strides within 3 centimeters of precision, regardless of the context of use. And I'm saying that because, I see a lot of people who are trying to develop endpoints on mobility based on the step count. So your smartwatch, your Apple Watch, and then so on. Right? And of course, I have a baby, so I count the numbers of steps I'm making when I'm shaking the baby. and you're smiling because of course we're all smiling and we say wait, that's not valid. That's not a valid tool, right? But a lot of people are running clinical trials with that, right? And then we understand that even non-ambulant patients, if they get a kit, well, they can regain ambulation if that's the level of evidence or validation we want to have, right? And unfortunately, so we have people who are on the left side of your screen, who are publishing things of analytical validation of those tools, so in this case it was the Apple Watch, but it's pretty much the same, saying, like the error is 0.034%, right? So like in my previous experience, I had 100% of error, right? So I did not make any steps, but my watch was counting like 30 steps, right? And then you have like scientists who are like fairly good scientists, right? Who have like, equipped patients on a treadmill, look at how many steps they were making, blah, blah, blah. You've done a huge protocol and then get to the conclusions. Actually, it's super precise with, less than 1% errors, right? And the real thing that we're talking about is trying to understand what is the context of use of your endpoints. Does it, and the context of use of my endpoint is I need to equip patients to not be at all aware of what are the type of activities that they are performing and still have a level of analytical validation that is good, right? And that's what's difficult in our problem, is like to try to infer steps from shock is fairly easy. Everyone has that on your pocket with your smartwatch. To get to the level of validation or analytical validation that you need, it's actually much more difficult. And I think that's why we had to reinvent, like a device that needs to be worn at a specific location with specific characteristic and so on. Right? So, and sorry, I'm going to have a few of the fun facts like that, but then I'll be a bit serious sometimes, right? Clinical validation is the other one which offers a second challenge. So the second challenge that we don't necessarily have in on the when you look at in clinics tests or patient or physician reported outcome, it's I understand that what's meaningful is when I measure not over like a short period of time, but when I'm increasing my period of time of measurements. Why? Because I'm looking at my patients in different life situations, and if I average out all of those signals, I'm sure that I'm not in a local or maximum or local minimum of my patients, but really like by averaging my signal, I'm removing all the short-term noise, and I'm only having the long-term signal, I would say, if you want to call it like that. So we need to have a bit of the understanding of, okay, what is good in terms of averaging out the noise that I don't care, because I'm not as a patient, as a human being, I'm not always on at my 100% performance, but still, I need to have a window that is short enough, because my clinical trials cannot wait for like 3 years, right? So I have to find this balance between, measuring enough life situation so that I have like good robustness, and measuring short enough so that it's practical in clinical trials. It's not putting too much burden on the patient and so on. And so again, this is on the right side here. We've taken a method that comes from electronics, actually the electronic stabilities of sensors, and that's an Allen variance, to try to understand, what was the viability of my measurements. So in this case, SV95C, when we were sampling it at different during different duration, right? So if you take and the graph are all different patients, and if you take at 50 hours, sorry, the mean of patient is roughly like I think it's 6.5%. So you have a viability of 6.5%, which is something that we can live with, and we try to say like optimally, we would love to be at 180 hours. Because you have less than 5% of viability on on your average patients, right? And that's what we call a robust endpoint. We know that some patients, because they have specificities, might not fall into those, but still, we are able to live with this level of noise, and this gives us actually like fairly good ICC reproducibility, robustness of the endpoint. Another one is not all endpoints are born equal. So if I was describing something a bit earlier, that a patient is reaching his top ambulation ability, 5% of the time, and that's that's really like a limit that the patient has almost built into him due to the disease. If we're looking at other things, so here we show, and sorry, it's a bit complex, but on the left side you have stride velocity, 95 centile, and on the right side you have the walk distance. So the walk distance is really what you would call the walking parameters. And we took the 5% longest walk that the patients were doing. And you can see, so here is in absolute terms with the, in absolute terms, and here is relative to the baseline. And you can see that relative to the baseline, the walking parameters is actually like not, so, and sorry, my bad. Let me just do a bit of a presentation on the disease. So this disease is ALS. It's a disease that is progressive very fastly. So you expect any measure of, any digital measure of this disease to be monotonically decreasing, showing, like the rate of progression of the disease. And if you measure walking parameters, so on your right, you can see that sometimes you have ups, sometimes you have downs, right? And that's essentially the patients who, due to these activity, his or her activity, is able to regain abilities to, or is able to push himself to do longest walk because his physio or his physicians has asked him to perform more activities, or because he has different, environments. And so as a result, you have a lot of perturbation on this, and that's a far less reliable endpoint than the endpoint that you see on the left, which is again stride velocity and face centile, where you can see monotonously that unfortunately you have some abilities that you lose, and you're not able to regain them. And that's in terms of if I translate those two graphs into the SRM or into values that we usually use to define an endpoint. So how large would be my cohorts to measure efficacy of a drug and so on. That has huge implication into those clinical design. And so the last one before opening it to the floor, of course, we have a lot of variable behind any endpoints that we're trying to put. And I think that the difficulty is to understand what's on this huge multivariate model, what matters, and what are the normative data that I need, what is the minimum set of normative data that I need to prove that your endpoint is valid to authorities, to physicians, and so on. I think, I'm just retracing a bit of two population here on Duchenne muscular dystrophy, which is again which is a neuromuscular disease, where you expect this disease is progressive, so you would expect the disease to decrease, but in the end, we know that young patients population, so the 5 to 7 here, are developing abilities to walk on top of the disease. So essentially you have one which is a patient who is growing and developing his normal milestone, but the other one you have the disease which is kicking in, right? And getting to the point of understanding what is the normative way, what is the disease way, what is what each of the parameters play, what role each of the parameters plays is actually super important into understanding your endpoint and developing your robust endpoint. And just to conclude on this, so this was only some of the challenges that we've seen for the clinical trials, so developing good endpoints for clinical trials. I think when you go from clinical trials to clinical care, you increase even more those challenges, right? Because the level of tolerance or variability that you expect is reduced from something that you can average over a cohort of n is equal to 20, 100, depending on your cohort size that you're looking at, to a cohort of n is equal to 1, right? So I think that those challenges get even more difficult. That being said, I think it's there are huge implications if we are able to reduce them. There are huge implications in terms of improving treatment decisions, into helping clinicians make the right decisions, into helping patients and physicians as well develop their personal targets, and as well, with payers, making smart payer schemes and so on. Right? So I think the level of things that we can do, or the potential of digital endpoint there is even more interesting. So now, I like this one because it's, especially when we are with statisticians, the right thing is to focus on, or is to really understand what is the important thing of your model, right? What are because of course you're the marketers behind the frog watch, and you try to define the three categories, right? Of like, is it affordable, is it frog, and does it tell time, right? And Rolex and frogs tell times, but only the frog is a frog, right? And so I think we need to be careful about defining the right characteristics that are important, because otherwise you end up having marketing bullshit where everyone is playing a role into pretending that their thing is working, right? So I think we in the end we need digital biomarker, I think, to improve clinical research, but we need smart people, smart biostatisticians, smart people to develop those endpoints to a standard where they will become robust, reliable, credible, trustworthy by all the companies. Thank you so much.
Thank you very much, Paul and Damien. We may have time for one quick question for understanding. If not, I would like to move straight on and welcome Craig. Craig Wang is working at Novartis since about 4 years, focusing on phase 2 and 3 trials, mainly in oncology, I believe. Yes. And I'm very curious, what are radiogenomics? So, thank you, Craig.
Thanks, Mark, for the introduction. So my talk today will be about radiogenomics investigation in metastatic breast cancer using data from oncology clinical trials. So this is a joint work between FDA and Novartis radiogenomics collaboration, which consists of members both from various divisions from FDA as well as from Novartis. So just a quick disclaimer before I start. This presentation represents views of my own, but not Novartis or FDA. We know cancer is a complex and devastating disease that impacts millions of lives worldwide. It's caused by abnormal cell growth, which invades other healthy parts of the body. Although we already know that there are many prognostic factors that lead to the worsening of disease, there are still many micro and macroscopic changes which we have fully understand. So oncology studies aim to advance the knowledge of cancer, its causes, including prognostic factors, as well as its cancer prevention, diagnosis, and different treatment options, which include predictive factors that lead to different treatment benefits patients may receive. New cancer treatment these days focus on not only delaying the tumor progression itself, but ultimately also prolonging overall survival of the patient. So having a deeper integration of the data can potentially allow us to have more targeted treatments, minimize the side effects of the treatment, and also optimizing patient outcomes. So to have individualized treatment options depending on what's the characteristics of the patient. Oncology has a long history of collecting various types of data. Mostly we look at clinical data, which we are used to collect and analyze as part of the regulatory setting. But there are new emerging data modalities like radiological data, so images from the tumor. We also have genomics data to look at gene expression. We have histology data of the tumor tissue itself, and then health records to cover a broader patient population beyond clinical trials. And then with all those data modalities, we can apply statistical methods and machine learning techniques to look at different endpoints of interest. Primarily, we look at tumor change. So those are typically to define how tumor progresses in different patients. But we also look at patient safety, when and how patients can experience adverse events. And also look at if some patients will have a different treatment effect than the rest of the patient population. And of course, digital endpoints, which I'm sure there will be more case studies in the later talks. So in my case study, this part of collaboration will be focusing on 3 different data modalities. The first is clinical, and then we have radiological data, so which are medical images, and then we also have genomics data. So just briefly on the collaboration itself. The collaboration between Novartis and FDA started in 2020. It's a joint collaboration on the scientific basis outside of regulatory setting. We are approaching complex new data modalities and using advanced analytics to integrate all those 3 data modalities I just mentioned. This collaboration uses anonymized clinical trial data from 3 phase 3 trials that are sponsored by Novartis, which is on the drug called ribociclib. It is a targeted therapy to treat metastatic breast cancer, which has been shown to improve both progression-free survival and overall survival of the patient. So we know the drug works, and we know it from the clinical data. And then as part of this collaboration, we are focusing on the scientific goal of evaluating and identifying, of course, the clinical data, but also, more importantly, the radiogenomics part of the data to look at what are the potential prognostic and predictive markers, and with the overall aim to advance public health. So hopefully you can learn something from this collaboration beyond clinical data, and that can be applied to other drug development and also the knowledge of cancer. Additionally, the collaboration also provides insights for both parties, Novartis and FDA, into research projects using machine learning and AI. So why breast cancer? It's a disease with high burden. In 2020, there are more than 2 million women diagnosed with breast cancer, with over 600,000 deaths globally, and majority of those are caused by metastatic disease. HR positive, HER2 negative is a common subtype of the breast cancer itself. And ribociclib, the drug we are looking into, is one of the treatment options, but also patient can take chemotherapy depending on the stage the patient is at. In such trials, the primary endpoint is normally progression-free survival. So this is to look at the change in the sum of lesion diameters. We have a criteria called RECIST, and based on this, doctors basically look at the number of lesions at baseline up to a maximum of 5, and then track them over time to look at the size of the lesion and determine when the patient have a disease progression. A common secondary endpoint is also overall survival. More about the research data sets. So as I mentioned, we have a drug called ribociclib. We have 3 clinical trials, 3 phase 3 trials to look at various combination of hormonal therapy with our drug versus hormonal therapy alone in a broad population. So we have over 2,000 patients that we enrolled between 2013 and 2016. And also we have a multimodal data sets. They were anonymized, starting from the clinical data, which include baseline measurements such as demographics, diagnosis of cancer, medical conditions, and then we also have more longitudinal type of data, which includes lab assessments, sequence of adverse events, so on. And then what's more interesting is that we also have radiology data collected. Those are typically CT, MRI scans from the patients of the tumor location, but also surrounding it with a subset of the patients having images annotated by radiologists, so contours on the lesion, which I'll go more detail about. And then we have genomics data. Those are gene expressions from archival tumor, and as well as circulating tumor DNA data from plasma samples. So on the figure at the bottom, we have a possible patient journey in terms of their data availability. So at baseline, this is when patients have the most complete data. We have clinical, radiological, and genomics data all collected at baseline. And then depending on the data type, they are collected at different frequency intervals. So clinical data is collected most frequent. They are also easy to collect every 4 weeks in this case. And then we have radiological data collected every 8 weeks because it has a certain negative impact if we do the radiology too frequent on the patient. And then for genomics data, we typically collect at baseline, but also sometimes at end of treatment because there's a high cost of collecting those kind of data. And here it's already a challenge to analyze all three data modalities together because those data are collected at different frequencies, as well as there are missing data problems at different time intervals. So just to go into deeper a bit more on each of the type of data. So first, we have clinical data, which we know that they are collected to address the main efficacy and safety objectives of the clinical trials. These are in typical ADAM data structure, which meets the regulatory requirements. They're in a tabular structure, and they have low proportion of missingness, typically. And here, when we try to pull across different trials, certain variables are not exactly collected at all times in all trials, which can limit the utility of certain variables. Below is just a visualization of how the data actually looks like. On the left, we have like a demographics table, which shows data 1 row per patient. And then on the right, we have a more longitudinal safety data collection, which shows 1 row per patient, per assessment time, and then per parameter. So this kind of data are typically, we are used to analyze them, and they are easy to analyze with different softwares, especially from a statistician point of view. These are tabular, so easy to work with. And then what's more interesting is that we have radiological data, so medical images. On the screenshot on the right, we have 2 rows of images. The first row is looking at how the lesion changes over time. The green contour is annotated by radiologists to mark where the lesion is located as part of the body. And then the second row is like a zoom out version of the 2D slice of the image. So here, I cannot show the 3D version because the slides we don't have a virtual reality here, but the actual data we have is actually three-dimensional images in DICOM format. Here is just one slice, but in fact there are multiple layers. A typical size is 500 by 12 squared by 100 voxels. Those images actually serve the basis of detecting the lesion and determining the disease progression status. Like actually in a clinical endpoint like PFS, we just took one-dimensional measure to look at the diameter of the lesion. And here you can imagine there's a lot more information available beyond what's just the diameter. And there's information surrounding the lesion itself, but also in other parts of the body that are typically not tracked by the RECIST criteria. And as a result, the features of these images, these three-dimensional images, are not readily available. So it requires a lot of intensive data wrangling prior to analysis, which our data scientist team can help out. Also, one challenge here is that the image quality varies depending on the image acquisition method, also contrast. So a lot of standardization is required to make sure that the imaging collected from different trials over a time period can be analyzed in a unified way. At the bottom, it just shows a file structure of the image data. It starts with a site and then patient, time point, location, and then some further different slices of the three-dimensional image. In total, we have around 5 terabytes of images from those 3 trials that are analyzed as part of this collaboration. And then we have genomics data. It comes from 2 different sources. One is archival tumor biopsy that are collected prior to treatment. So those are gene expression data generated using the nanostring technology. It targets over 700 genes, and they are enriched for genes implicated in breast cancer as well as immuno-oncology. Second source is plasma samples. They were also collected prior to treatment to assess the circulating tumor DNA. So those are based on next generation sequencing, and they were used to sequence over 500 genes from cancer-related pathways. So both of these genomics data are high dimensional. They have a high sparsity. In ctDNA data, there are many genes that are infrequently mutated, leading to sparsity in the dataset, mostly ones rather than zeros. And then for gene expression, they're also highly correlated, which means some kind of pre-processing is also required to reduce the marginality and to do feature engineering before they can be inputted into some modeling methods. So each of the three types of three data modalities, they have their own characteristics, and they require different expertise to know the best way to extract features and process them. Also, in our project, we want to consider all three data modalities simultaneously, which requires us to develop some generalizable, some flexible analysis pipeline that can accommodate both models using a single data modality or multi-modality datasets. So on the right figure, we have a schematics of how we approached to establish the data usage. So we started to conduct exploratory data analysis just to look at for which patient the data is available from which data modality. Of course, here we are keeping our research criteria in mind. We would label each patient either green to have the complete data modality, or having one data modality and then rank them accordingly. After having an understanding of what's available in each trial, then we would stratify the patients by their data modality as well by the trial to partition the patient into training, validation, and testing data sets prior to any modeling. So this avoids data leakage and ensures that our test results are robust in the end. Also, by doing this, we ensure that each data partition is well represented in terms of not only the data modality, but also the slightly different patient population from each trials. After established the data usage, we also designed rules to ensure robust model training process and a consistent comparison between different models. So on the right, we have a flow diagram that clearly documents how we would approach to train, combine, and compare the different models. So different color is depicting different data sets. And then it also shows when we can use which data set and which situation, and when we can take the learnings from model building process and go back to start again. Because we have a big team of statisticians and data scientists, having such a aligned flow diagram ensures there's a correct way of using the testing data set, but also have a flexible framework to accommodate both uni and multi-model training. Throughout the process, of course, we follow good data science practice to write reusable code, to share them across language, but also computing platform between Novartis and FDA. When it comes to interpreting the model, we aim to make some kind of clinical impact, which is not easy in the presence of multi-modality data sets. Especially the imaging data is 5 terabytes. It's not easy to extract features from it, and it relies on using machine learning and AI techniques. There are different ways we can combine the different data modalities together, such as model fusion, which can further complicate the interpretation part, because when we do, for example, late fusion, we lose track of the original features from each modality, but we will end up with some kind of aggregated features, which requires additional step to be able to interpret the model outcome. And this also requires us to engage with our clinicians to understand what's the target interpretation they are looking for. For example, most of the models from machine learning would end up with an aggregated risk score, a rank-based score for the patient. And this is not super helpful in clinical practice. What they would be looking at, what they would be interested in is to have some kind of probability prediction for patient survival at a certain time point. So this requires extra translation of the models. And as we are already a few years into the research collaboration, we started to publish some of our work from starting from a prospective analysis plan to publish how we intend to approach this problem to make our end result more robust and reproducible. There was also a talk at FDA Scientific Computing Days to look at the data sharing part of this collaboration. We also recently published a tutorial paper that could help other scientists to explore navigate such a complex multimodality data in principal way. And then one of our first results publication is led by FDA author, which looks at how delta radiomics model can improve the prediction of PFS in metastatic breast cancer. So new data modalities comes with opportunities, but also challenges. So I would like to end my talk with 3 take-home messages. The first one is prior to analysis, conduct extensive data exploration. Because oftentimes those data were collected some time ago for different kind of purpose, for different kind of research question. And here, when you reuse them for some additional exploration, it's important not only to look at the data, but really starting from the availability of data for each components of, for example, different trial, different patient, but also assess the quality is suited for purpose. And then the second point is multi-modality research requires interdisciplinary team with domain experts. I think this echoed the point from Dominic early on about federated learning that is interdisciplinary. And here it's not only data scientists, statisticians, but also clinicians, imaging experts. So those domain experts who know not only about the data, but also the acquisition method, how they were obtained, and their utility in clinical practice. And then in the end, because of the complex data structure and the heterogeneity within it, there are extra efforts required to ensure the end results are interpretable and clinical meaningful for the patients and for the doctors. So thank you. Welcome.
Thank you very much, Greg. We again have time for one very quick question.
Yeah, actually, I was kind of missing what you did. So you spoke along about the pre-processing and the pipeline. So maybe just an example, how did you handle the multimodality? Did you hand engineer features and then put everything together, or was there anything on top of that?
Yes, so we are considering different options. So there are more details in one of the manuscripts that we published. Of course, we are not at the stage of sharing all the results. We are still analyzing the data. But in terms of combining the features, there are like early fusion, intermediate fusion, and late fusion. So different stage of your modeling where you can combine the features. Early fusion is I would say the traditional way where you take all the features, say you have 10,000 features, and some of them from imaging, some of them from genomics and clinical. You analyze them from the start in a single model. Late fusion is where you can lose certain information. In this case, then you would build different models from each data modality, and you combine their outcomes in a second stage modeling where you would aggregate it. This is the part where you lose some of the original features, and it can be challenging to interpret. So right now we are still at the stage of comparing different approaches.
Thank you. I'm afraid we need to move on. So I'd like to welcome Stanislas Hubot. You were at Roche,
I am
right?
at Roche, yes.
Since about 10 years.
Yes.
And yeah, before that, I think you were at EPFL. So we have a
Exactly.
second speaker
Yeah.
actually from the same institution, and I'm very curious to hear your talk.
Thank you.
Let me try to find it.
I think it's still here, but you just need to change tab.
Ah, you're right. Okay.
Yeah, that's the one. Okay.
Thank you.
Superb. So thank you very much, Mark, for the introduction, and thank you for the invitation about this topic, which will be about opportunities and challenges when developing a digital endpoint, and I'm going to use Floodlight as a case example. So as Mark said, I'm Stanislas Hubo. I'm a principal statistical scientist at Roche, and I have been the project lead statistician for Floodlight for the last 6 years, so quite a significant part of my life. My talk will be in two different parts. I'll start with a quick introduction about Floodlight, just that we ensure we're all on the same page, and then I will jump into what I consider as the interesting part, which is how can we use these high-density data in a longitudinal context. What is Floodlight? If you Google Floodlight MS, you will most likely end up with the image that you see on the right. That's Floodlight. It looks like an app on a smartphone. That's what it is, but it's not only that. It's much more than that. It's not a single hardware or software technology. It includes, for example, an HCP portal, a patient portal. We're looking into active tests as well as passive monitoring, several technologies, and of course, all these technologies are not at the same stage of development as of today. Floodlight is for patients or people living with MS, and we have a quite bold strategy, which is people can download Floodlight on their smartphone as soon as it's compatible, of course, and if their physician is part of the Floodlight program. But we're really not willing to add additional burden on patients with an additional device. We want to use what is in everybody's pocket, which is their smartphone. What are we willing to do with Floodlight? Well, that's the kind of typical disease trajectory of a patient living with MS, with some relapses and some progression over time. If you only have the information collected at the clinical visits, that's the red squares. So you can see it's sparse and potentially it might also be missing some important information. If you add any sensor outcome, so Floodlight, could be Cessna from our colleagues, you will end up with all of the blue dots, which are filling the space between the red squares. And what the vision is for Floodlight, it's that it's really going to put some light, sorry for the bad joke, but some light on kind of hidden progressions. And for patients with MS, there's really two kind of hidden progressions that we're interested. It's the PIRA, progression independent of relapse. That's the part you see on the left. You see first a slow increase, and then you have the relapse. And this slow increase, you would miss it just with the clinical variables. And then the second example is this little peak that you would have, which is not captured by the red squares, which are absolutely identical if you would not have any sensor outcome. So of course, any sensor outcome will enable you to have high density data, but for Floodlight, it's much more than just doing the same test a lot of time. This is from the draw a shape, which is a hand test. You're just supposed to draw some shapes on your phone with your fingers. And as an example of the granularity of data that you can get out of one test, here you can have the accuracy, and you see how different a healthy person is from a patient from MS. You have celerity and you have speed. And that's only 3 examples of the granularity of data that you can have out of Floodlight or any digital health technologies. And promise, that's the last slide about Floodlight. Where are we today? Well, we're developing active and passive monitoring tests. It's deployed in several of our clinical trials at Roche, but also in collaboration with other companies. So we have approximately 2,000 patients, with some of these patients followed for more than 4 years. That's quite unique in the digital health space. And we're targeting to have more than 3,600 patients. Floodlight is also an SAMD, software as medical device, so it's available on the market in 10 countries. We have more than 1,000 users which are using this in their normal clinical practice. And for full information, we didn't launch the full test that we have available at Floodlight, but only a subset of the active tests, which are here highlighted in blue. That was all about Floodlight. Now we can go to the statistical and interesting part of my talk, which is about longitudinal use for high-density data. When you're developing your DHT, at one point you will come up with an important question, which is, do I have the longitudinal association with my gold standard anchor? Whatever it be, it can be a clinical measure, it can be a PRO, whatever is the gold standard in the therapeutic area that you're interested in. And that's, as I said, really important. But to be able to do this longitudinal association, it means you need to be able to define longitudinal for your DHT or digital health technology. What you could do, of course, is simply take your clinical visits, you aggregate around them, you get 2 endpoints, you do the delta, very standard to what we do in everyday clinical practice, sounds good. But if I take my example of here, a patient where I have a lot of data points over time between 2 clinical visits, if I aggregate, I would have the 2 green triangles. If I do the delta, no real difference. But if I look at the whole trajectory of all the data points that I collected, I see potentially signs of disease progression. And that's what we're willing to do, to use the full information of the data we have collected thanks to the DHT. Before going to the definition we used, it's important to understand where we are currently in MAS with clinical anchors. The main endpoint used is called time to confirmed event. So in a nutshell, you would have the 2 patients A, the purple one and the orange one. They start somewhere, they have a progression, that's called IDP, initial disease progression, and you need this initial disease progression to be confirmed after a specific time period. For example, here it could be 12 weeks, so the purple patient doesn't have a confirmation because he's back to its initial level, while patient B has a confirmed progression. And really what we want to do is take this concept and translate it into high density data. So as I said, how are we going to take these kind of continuous high density data that we had before into time to event endpoint? If you would think like, okay, we just say at one point of time, all the data points are below a specific threshold, all good. Well, yeah, but with the variability of data collected in a home setting while using their phone, the variability is quite high. So asking for absolutely all data points to be below a specific threshold is just not realistic. So we need to construct something with these data. And the idea was to construct first a smooth curve, and I'm going to go into details of how you do this. So that's the green line. And then you construct some confidence bounds around these green lines. And the one thing that we wanted for these confidence bounds is that there should be sensitive to the number of data points used to construct the smooth curve in the local area. Such that in this example, if your confidence bounds are the blue arrows, you can see that when we have a lot of data points, the arrows are quite narrow, and then at some point the patient does less of the DHT, and then you see your arrows becoming much larger. And that's what we want. And once you have this confidence bands, then you can request the confidence bands to be below a specific threshold, similar to the concept of the clinical metric, but not all the data points, only the confidence bands. Mathematically, how did we do this? Well, it's a methodology that was developed by the professor Peter Brunlin. He's a professor at ETH, the Swiss Institute of Technology in Zurich. And we had one of his students, Zheng-Chen Man, who implemented this methodology into an R package during an internship. The R package is available to all of you. You just type EDCOB on CRAN and you will have access to the package. EDCOB stands for Event Detection Using Confidence Bands. Staying very high level in mathematics because I don't have the time to really jump into the fun, but the idea is that you construct your smooth curve that's using a moving median. Then you apply an autoregressive model on the residuals of your moving median. And then you will bootstrap the residuals of your autoregressive model. And by doing this, you find pointwise confidence intervals. And then thanks to these pointwise confidence intervals, you can construct the simultaneous confidence bands. All the methodology is explained in the EDCOB package. I'm also happy to take questions, but that's a very high level how we construct it. So how does it look into practice? Well, the first thing we wanted to do is ensure that the nice theory that we had on the paper translated into something accurate when we simulated data. So we simulated a lot of cases. I'm only presenting 3 here just because of the size of the slide. The first example on the bottom left, that's the ideal case. You have a patient, he does a lot of assessment all the time, a lot of black dots, and you have this nice progression. You construct your moving median, that's the orange line. And from the moving median, you construct your confidence bounds, that's the purple area. And you can see that your purple area remains below your threshold, which is the horizontal red line, remains forever. So we define an event as the red triangle, easy case. And you can already see that in this case, all the black dots are not below the threshold, the horizontal red line. So that's already the big advantage of the confidence bounds. The second example is the patient is very adherent, then for some reason, less adherence, and then again, very adherent. And if you would just look at the black dots, all the black dots during this less adherent period are all under your threshold, the red line. So you could have said like, he has an event, all my points are below my threshold. But if you construct the confidence bands, which are nicely larger when you have fewer data points, you can see that it crosses the horizontal red line, and so we cannot define an event because the patient doesn't have enough data points in this area to be sure about his disease status. And then the last example is when you get fewer and fewer data points and same or similar to the second one, where we can see that we cannot conclude that the patient had a progression at the tail of the data points because of the confidence bands. So the theory seems to work quite nicely in our simulations, and we get what we were willing to have. But that's only the beginning, because once you have your analytical validation, you also need to have your clinical validation, as it was mentioned in other talks. And what it's all about is seeing the events which are detected by classical clinical measure. Can we detect the same events or potentially even more when using our digital health technologies? So this work is still ongoing in the Floodlight team, but we have already some quite promising results when we were looking at in each individual patient plot. So it's the same than before, except that now it's real patients. That's not simulation anymore. It's really how we captured the data from Floodlight in people living with MS. And we also added in blue, that's the line, the clinical information that we captured. So it's 25-foot walk test. That's a quite standard test in MS, and it's expressed in speed. And what you can see in the first example is that the progression as per the clinical metrics, so you can see this drop in the blue line, is quite well synchronized with the drop that we observed on Floodlight, and which is maintained afterwards. So this is really kind of where everything is well synchronized. And then we have this second patient where, as per our definition of an event on Floodlight or on our DHT, it's earlier than what you can detect with the clinical measures. You have this initial drop that you can see is exactly between two clinical visits. That's a real case, I didn't make it. So really it happens like this. And you can see that potentially we can detect the progression earlier than with the standard clinical metric. And when you know how important it is to treat the patients before the progression in MS, that's really where we're having a lot of expectations. What are the next steps? Well, obviously, just looking at patients individually is not enough for clinical validation. So we need to look at proper correlation. We're also thinking potentially to go up to surrogacy of the clinical anchors or the clinical metrics. So that all of this needs to be done and finalized. What I find really fascinating on this topic is that sky is the limit when you think about change on high density data. Here, we're still focused on this idea of a delta. We want the data to change and remain below a threshold for a certain amount of time. But we also started looking into other things, and that's a non-exhaustive list, but simply also looking at the change in the variance of your data. Is this indicative of a progression? So we have here colleagues, Vittorio, who looked into this to try to define how does a change in variance is indicative of disease progression. And then what I find very interesting in digital health technology is that probably what you don't see is as important as what you see. And missingness can carry a lot of information when you think about patients doing digital health technologies at home. Think about patient feeling bad. I guess the last thing they want to do in their day is take Floodlight and start doing, some active tests. So these missing might be very important, and that's why we also say or remind everybody as soon as we can, missing at random in a digital health technology setting probably isn't true. Of course, we also have challenges. I have here just two of them, again, not exhaustive list, but I find them very interesting. So these high density data, like daily assessment, and I know my colleagues from CISNAV said you can do this forever. I personally think that no, it's kind of suitable for a short amount of time. You can ask people to do this on a daily basis, a couple of months. But if you think about MS, where clinical trials usually last for 3, 4, 5 years, can you really ask patients to do this on a daily basis for such a long period? I think it's going to be very challenging. And then the last one, which I think is interesting because it's also one of the assets of the DHT. It's continuously evolving. It's getting better. You have like new versions, potentially also correcting some bugs. But all of these new versions that you would deploy, well, if you think about the longitudinal use, you need to be sure that this new deployment is not harming your longitudinal use. So the data you will collect with the new version still needs to be comparable with the data you collected with previous versions. And you can think that this is coming from granted, but in reality, you need to prove it. And it's not that easy to prove that the data collected through different versions are equivalent. So to summarize, I like this image of the iceberg. We really only touched the top of the iceberg today. There's a lot of other topics I could have talked about. It goes from data quality and accuracy, learning practice effect, data privacy concerns, and so on. But I hope that with the small grasp that you had today, I have convinced you that really there is potential to really uncover these hidden progressions that matter for the patients. Of course, it comes with some challenges. I have one final take-home message. If you just keep one thing out of this presentation, on top of the fact that Floodlight is great and that we can uncover hidden progressions, is really about the context of use. And I really enjoyed that Damian from SysNav also mentioned the context of use. I see a lot of people, we get the data, the DHT data, we jump into doing the analyses like, yeah, we do some plots and start doing slide decks. But before doing all of this, just take 1 minute and ask yourself, are the 3 main pillars of my context of use defined? Which are the disease and target patient population. Do I know for whom my DHT is targeted? The study type in which I want to deploy my DHT, non-pivotal, pivotal, the trial design. And lastly, the measurement as well as the administration principles. Do I know how often the patient needs to do the test, or how many assessments do I need to aggregate? Because if you don't have these 3 pillars, it will be very difficult to do fit-for-purpose analyses. So that's my final take-home message. Thank you for your attention, and I think we take questions now or later.
Maybe we push the questions to the panel discussion because we're a little bit late. And now I'd like to welcome, I hope this works, online, Sheila Jagannatha. Hello, can you say something?
Yes, can you hear me?
Perfect. Thank you very much. No, we hear you perfectly. So Sheila works at J&J in the statistical modeling group, focusing on digital endpoints. And now we need to find the slides. Thank you, Uli.
Do you want me to share the slides, or are you going to share the slides?
What you prefer?
Let me share and see if I can do that. So I can point my cursor. And let me know if you can see my screen.
Not yet.
Okay, let me share again. Oh, well, I'm sharing. At least it shows in mine that I'm sharing. So maybe we should go with yours.
Okay. Just let me know when I need to skill it.
Yeah, just go ahead. I can't even know where to stop sharing.
It's coming. Can you see it?
Yeah, I can see the screen.
Okay, thank you very much, Uli.
Okay.
So, floor is yours. Just
Okay,
let me
great.
know.
Yes, and looks like I am the only presenter who is online. So thank you for bearing with me, and thank you for giving me the opportunity to present at this forum. I will walk you through a case study where we had where we used actigraphy data to define endpoints. And next slide. We can skip this slide in the interest of time. I can go to the next slide. Why don't you click all that, make the slide full, so we can do the. Great. Okay, so I want to, the indication of this case study is, you can go ahead and click more. I think there's more, one more. Once more, maybe? Okay, great, that's fine. So the indication for this case study is pulmonary arterial hypertension. I will quickly go over this disease and why actigraphy in this indication. PAH is a rare and debilitating disease affecting the lungs, the blood vessels of the lungs. It is characterized by non-specific symptoms such as reduced exercise capacity and difficulty in breathing or labored breathing. The most commonly used endpoint for this indication that's been used is a 6-minute walk test used to assess the exercise ability of the patient. And 6-minute walk test is basically what it sounds like. The subject goes into the doctor's office and the patient is made to walk for a duration of 6 minutes, and they measure the distance that the subject walks in the duration. It is non-invasive, easy to capture, and it captures the submaximal exercise capacity. But however, it's not, it's a snapshot of the subject's performance. The subject goes in the doctor's office, so it can be performative. It's not the most optimal. And that's where actigraphy comes in. Actigraphy can be provide more granular, patient-centric, and accurate measures to assess changes in the status of the subjects in their daily functioning, and it can be measured in real life. And so, actigraphy can be a useful measure in this indication. For this, J&J had a phase 4 study that was designed to address the question whether actigraphy can be used to assess changes in daily life physical activity in patients with PAH who are receiving either placebo or selexipag. Next slide. We can go to the next slide. So this is the design of the case study. It is a double-blind randomized controlled trial, parallel groups design. The subjects were randomized to either placebo or selexipag, and the duration of the study was 24 weeks, and with a 30-day follow-up. The key takeaway from this, if you want to know more about this study design, I have provided the reference, and you can look it up. It was published earlier this year. But the takeaway from this is that each subject was given a device, the Actigraph device GT9X link, and they were asked to wear the device for 24 hours a day for the duration of the study. So when the study finished, we had very rich data set of actigraphy data on about 108 subjects for 168 days for 24 hours a day. So this is, as you can tell, very rich data set from which we can learn a lot about actigraphy in this indication. Next slide. So how did we use this actigraphy data? How did we use actigraphy data in TRACE? We had minute level data to define endpoints. So using the minute level data, we defined several endpoints to assess. Some of them I've kept, for example, it was the total number of steps per day, or the number of minutes the patient spends in moderate to vigorous physical activity, and other. So there were several endpoints that were defined to capture this daily life physical activity. So when we define this, the total number of steps per day, we need to define what constitutes a valid day or a complete day. So in this study, we arbitrarily defined that if we have 7 hours of awake and wear data for a subject, that can be considered that it's good enough for us to capture the entire, to give a good idea about the physical activity of the subject for that day, and that was considered a complete or valid day. With this aggregation, we will have, I know we are doing a lot of aggregation. This study was finished 4 years ago. It was started a while back. So the approach, discussing the approach of this case study, and we can debate that, discuss it more later. So we will have, with this aggregation of daily, we will still have about 168 days for each subject. we wanted to look at the change from baseline. So we wanted to aggregate it further to see, I mean, in a 2-week interval, like, what is the mean activity in the 2-week interval at baseline and then at 24 weeks. So we further averaged the daily data in a bi-weekly period. And for that, we needed to define what amount of days are considered valid in a 14-day period. Again, arbitrarily, we chose 7 days out of the 14-day period, consecutive or not. And if we have 7 days of 7 hours, 7 days in a 14-day period, that was considered valid to aggregate for the 14-day period. Then, but these, you can see a lot of these kinds of definitions in the literature, like how many hours constitutes a complete day or a valid day or per week. And they are all over the place. The commonly used wear time can vary anywhere from 3 to 10 hours per day, and wear days can be anywhere from 4 to 7 days. So, and there's nothing for this indication. So after this kind of aggregation, the analysis was performed assuming missing at random using MMRM. And using this kind of aggregation, the compliance in this study was very high. Okay, so this was what was done. So next slide. Okay, briefly, I'll quickly give you what this actigraphy data looks like. This is the raw data that we work with to extract the endpoints. This is a few records of each of a subject. The first column is the timestamp. It's a minute level timestamp. The second column is the number of steps per minute. And then the steps is actually based on it's a proprietary algorithm. I think right now it has been published. It's available publicly, but at that time it was still proprietary from Actigraph on how they calculate the number of steps per minute. The next 3 columns are common to any device that has a 3-axis accelerometer. Any device that has an accelerometer that captures movement will have these 3 columns. The x-axis measures the movement from front to back, the y measures it from right to left, and the z measures it from top to bottom. So the sleep awake, a column categorizes each minute as awake or not awake, and this is also based on an algorithm. And the wear also is based on an algorithm where the subject is wearing the device or not wearing the device. The wear is false, and that is considered as missing data. I know we had several endpoints, but for this, what I'm going to show you, we just wanted to approach it with something that doesn't use any thresholds, it doesn't use any cut points. We just wanted to look at the vector magnitude per minute, which is defined as the square root of the square of these 3 XYZ axes for this. It's very commonly used and calculated. Okay, next slide. This is a very nice visualization of the actigraphy data. The x-axis is the 24 hours data, and the y-axis is it's a 1 month data for a subject. Each row represents 1 day of a month, and the x-axis is the 24-hour period. You can see that the purple dots represent the activity level. The darker the dots, the more active the person is. And these white spots here, they're between the 6 a.m. and 10 p.m. What you can see, that's where the wear category, the wear is a non-wear. Based on the algorithm, it indicates that the subject was not wearing the device. And then if you look at the left part, there's a red line that indicates that there was missing record. So there was no signal from the device. And we did this, if you look at this for all the patients, we decided that if you look at data from 6 a.m. to 10 p.m., we are capturing activity of most patients during their awake and wear time. And so for our work, we will focus on this time period. But this subject, you can see, did not have that much missing data. It was pretty good. Okay, next slide. I can come back to this in the interest of time. Let me move on to the next slide. Okay, so this is the entire data of their for two subjects for their time during the study. The x-axis is the time during the day in 15-minute intervals. It's a heat map, and the y-axis is each row is 1 day, and so the x-axis is the time period of the day. If it's red, they're more active. If it's blue, they're less active. And you can see this subject didn't have the full 168 days, but the white spaces represent missingness, and you can see I can't really see a pattern in this missingness. And but when you look at this subject, you can see that it looks like once a week this subject has some missing data consistently every week for the same times. And if this during this time period the subject is removing the device to go swimming, then the activity would be higher. But if the subject is getting a massage every week or going to the doctor's office removing the device, then this would be less active. But we can go to the next slide. Without knowing much about what is causing that missingness, it's very difficult to decide whether the subject, to me, the right plot looked like missing not at random. So it's very difficult to decide what the missingness constitutes. I won't go over these in detail because the MCAR, MAR, MNAR can be different for different endpoints, different devices. How we define the endpoints all can play into how this matters. But what the key takeaway from this is that all this leads to this question based on the previous one, like what data do we need to collect when we are collecting digital data from digital technologies in clinical trials for us to better have an idea of either understanding missingness or even later time to impute, to do some imputations. Having this data would be helpful. And also, there could be more than one missing data mechanism that can be happening for a patient in a given day or over the course of the trial. Next slide. So this protocol, it was a phase 4 study. I'm not sure I mentioned that. It was submitted to the FDA, and we got some feedback from the FDA on the analysis that we had proposed. They asked us to justify if those thresholds that we had used, the 7 hours, if that's a representative sample of all activity during a day, and if the 7 days that we had proposed is a representative sample of all daily activity during the 14-day period. And then they asked us to do some sensitivity analysis and conduct some MCAR. But for this presentation, I will only focus on the first, on approaches to address the first bullet, the first feedback. Next slide. So what are the steps that we took to approach the first feedback from the FDA? So as I mentioned, we focused on the data from 6 a.m. to 10 p.m. That is a 16-hour time period, and where most of the subjects had their activity. And each subject was in the study for, say, they were supposed to be in the study for 24 weeks, right? So we have X number of days for each subject in the study, say 168 days. And then there were some days each subject had complete data with no missingness in the 16 hours, and some days where they had missingness. So what we did was took those days that had complete data for each subject, looked at their missing data patterns from their incomplete days, and then induced missingness in the complete day data. So we have 2 data sets of the complete days. We have the complete day, and then we have the data that where we have induced missingness on that. So we'll be able to compare how the missingness is affecting that. And we did that for each patient. Then, like I said, for this exercise, we focused on just the vector magnitude. We looked at the median vector magnitude. And basically looked at see if the missing data, the vector magnitude, the missing data is a good predictor of the full data set, given a certain number of missing hours. say from 1 to 14. If this vector magnitude and the missing is missing 1 hour, how good a predictor it is of the full data set. If it's missing 14 hours, how good a predictor it is. So basically looking at the slope. The other measure that we looked at to see the effect of missingness is the percent bias, where we looked at the difference between the medians of the full and the missing and expressed it as percentage, and then regressed it on the number of hours of missing data. Next slide. This, like I mentioned, this shows you each column is one subject, and the x-axis is the each subject. So the blue represents the percentage of days that each subject had that was complete from 6 a.m. to 10 p.m. The red represents the percentage of days that were missing. And this is what we used there, each patient's own missing pattern to induce missingness in this blue where they had complete data. And this was done using the ampute function in the mice package and assuming a missing at random assumption. Next slide. This is a picture of the missing data pattern from the incomplete days for one subject. We can go to the next slide. So this this would have been all blue. So this is a complete data, but we have induced the missingness based on the pattern we saw in the previous slide. Each square here represents a 15-minute time interval from 6 a.m. to 10 p.m. except the first two columns. And this represents the data for this subject where missingness is induced in the complete days, in their complete days. Okay, next slide. So when we looked at the slope, how good a predictor the incomplete day is for the full day, you can see the first, the blue line. The x-axis is the number of hours of missingness, and the y-axis is the slope. If we don't have any missingness, which should be 1. It's predicting perfectly, and then you can see the slope starts decreasing. It starts going down. If we draw a line through it, you can see that, again, I'm setting a threshold here. You know, if you want the slope to be 0.99, 0.95, I'm setting a threshold of 0.95. And if we set that threshold, we do not want the missing hours to be more than 8 hours. That is, even a 16-hour period, we would want at least 8 hours of wear time. If we look at the red line, it looks at the bias. Right? And if we set again an arbitrary threshold that we don't want the bias to be more than 5%, we say we do not want the missingness to be more than 10 hours, which means that we should at least have 6 hours of wear time. Between these two methods of looking at what's a good valid day, we can say anywhere from 6 to 8 hours of wear time is reasonable. So the 7 hours that we used was probably reasonable. I'll get to that in just a second. But one thing I do want to mention here is that when we're looking at bias, we need to consider the MCID, the minimally clinically important difference, because if we say a threshold of 5% bias is acceptable, but if we are saying that the MCID is 5%, then it affects. We do not want the missingness to be so high that the bias and the MCID are the same. And then we may want to keep the bias to be much lower and have more hours of data, non-missing data. Next slide. So did we justify 7 hours of wait time as sufficient? As I mentioned, as going through the slides, it's one simple metric. Doing this approach, this needs to be evaluated for the other endpoints, and we should understand if the thresholds that we have used are acceptable. The missingness that was induced, assumed missing at random, again, as I think the previous speaker also spoke that in digital health, missing at random really is questionable. And given all these caveats, 6 to 8 hours of awake and wear time gives a reasonable estimate. So given all these caveats, 7 hours was acceptable, but there are a lot of caveats. Next slide. Let me know if I need to go over quickly if there's time. There have a few more slides about the number of missing days in the 14-day period. We used a similar approach.
So Sheila,
Yeah.
just to answer your question, we're 2 minutes over, so if you could start wrapping
Yep.
up, that would be great. Thank you.
Okay, so I will say that we used a similar approach to justify the 14-day sample, a 14-day window. We can go to the next slide. Let's go to the next slide. I think I will, it's a summary slide. So what we found was that the mean really didn't change. If you are missing 1 day or if you're missing 10 days, where the mean the bias started to occur was, if you're missing more than 12, 13 days like that. So how do we decide what is the length of the duration of the measurement that we need to take? I used an approach that they used in psychometric tests where to get a certain reliability, how long do we need to have the test? And using the reliability measure for each day, if we want reliability to be 80%, we need to have at least 5 days of data, given the reliability to be 0.44 for a 7-hour day. If we want it to be 90%, then we would need to have 10 days instead of 5 days. So next slide. So the concluding notes I want to say is, yes, based on the approach that we used, it seems what we used was reasonable. Again, the methods, the endpoints, the threshold, it has to be evaluated for different endpoints. Sensitivity analysis has to be performed and reconfirmed again for a different measure population. I want to wrap up by saying currently, as we have been discussing, there's an explosion of digital health technology that have potential for precise and timely assessment of health points. We are currently in the stages of developing and validating the endpoints, which is, as you know from the previous presentations, it's not a small task, but we are progressing. In the near future, we will have endpoints that will become primary and secondary and will be used in registration of clinical trials. And the questions around what type of data to collect, how to define, address, and impute missing data will become pertinent for all statisticians. And we need to start having those discussions now. And this is an attempt to start that. Thank you. I would like to acknowledge the support and the collaboration I received from my colleagues at J&J. And I think the next slide also has some references to this discussion. And the next slide has, yeah.
Thank you. Thank you very much, Sheila. Please stay on if you can. We'll have a panel discussion now. I will hand over to Lilla. Thank you. All the speakers, I guess, should come on stage.
Please. If all the speakers could join me on the stage, that would be great. Can you hear me, Shaila?
Yes, I can hear you, Lilla.
Super. Okay, great. So great presentations, really thought-provoking ones. It would have been nice to have even more time with each of you, but we have about 20 minutes for a bit of panel discussion, so let's try to take advantage of that. I see. So first of all, if anybody from the virtual audience has a question, please, this is the time. Please write it out and I will read it out. Let me just make first one question about this to all of you. It's about pre-specification. I heard a lot about, being flexible, iterative processes, and this kind of grates against the possibility of doing some pre-specifications in the analysis plan. Somebody, I think it was you, mentioned the analysis plans. How can we, embed this kind of learning attitude, but at the same time, try to go with an assumption and pre-specify as much as we can, especially if we think that some of the uses of what we're doing here, and I'm talking both on the data modalities as well as the federated network, some of it might have some regulatory value. Up to you for
I'm happy to go first. So in the case of Floodlight, as you well said, you need to find the right balance between the iterative process. And the development of a health technology is really, for me, one of the field where we have the highest iterative process. And also what I discovered through the development of Floodlight is that there are activities, and Shaila mentioned the MCID, for example, where you would think, oh, I compute this at the beginning of my development, I have my values, and I'm good for the next couple of years. But you see, and Shaila mentioned it very nicely, it will depend on your final endpoint. And between the time where you developed your MCID and your final endpoint, you might have changed. So you need to go back to computing your MCID, and these iterations are happening a couple of times. What we did as an approach on Floodlight is, at the very beginning, the data that we had, we split them into data that we can play with and data that we have firewalled for one day where we have an important milestone such as regulatory interactions. And as of today, they're still completely firewalled. We didn't touch them. What we, on the other hand, have also noticed is whenever you start the development, it's important to agree on the scientific questions you want to answer. And this is important within the team, with all the departments. You agree on the scientific questions, and then the stats people can go iterate on multiple methods and then come up with an option. But if you don't agree on the scientific question at the beginning and you do the opposite, is you do the analysis and then you see what scientific question can I answer with my analysis, it's going to go in all directions and completely uncontrolled.
I think maybe
Can I make a comment?
Yeah, Shaila, go ahead, please.
Yeah, I just wanted to make a comment. I agree with that. Pre-specification is challenging when we have a lot of questions and we are not sure about many of them. But I would say a lot of digital devices are currently being used in phase 1, in sub-studies, in many protocols. And I don't know how much the statisticians are paying attention to that. So maybe learning from that, like all the questions that we have, how much can we learn from that? If we put resources into that at this time, then maybe when during the later part of development, it may be useful. But that's a specification of some things, not everything.
Yeah. Dominic, you wanted to add?
I think for federated learning is probably very similar. I mean, it should be pre-specified. I think one of the challenges always you deal with real-world data. For certain methods, pre-specification is challenging. So you pre-specify in an algorithmic way what you're doing, but not all basically kind of the key ingredients, the characteristics, the parameters. But I think it's one challenge. It's pre-specification when you develop something where basically also what we heard before, the data modalities are coming in at a certain time point, right? It's still, you develop, you pre-specify, but you need to allow within the methods kind of like some flexibility to really.
Maybe I can just add one point. I think pre-specification also outside of regulatory setting is not really before you start looking at the data to write an analysis plan. That can also happen that after initial exploration of the data, before that you do any hands-on further in-depth analysis, you pre-specify something that first it avoids publication bias, would make your entire analysis pipeline more robust, but also helps the entire team to have a good understanding of what the scope of the analysis, what are the objectives, because without the analysis plan, it's hard to, it's easy to diverge into multiple directions. And this is the central document where it not only helps to reduce bias, but also help to keep everyone on the same track to have the common objective aligned beforehand.
Anastasia, anything?
I agree with, but it's important to specify a task. I have not much to add, maybe just what in some cases is like even difficult to specify maybe a good task, especially like in this federated learning setting where you don't know the data and you have no access to it. And sometimes even like in some applications, for example, if you want to learn from images from like mobile phones and you want to like do some segmentation task, these images have no labels. There is no segmentation available for images. It's like no one can label actually this data, and this is also a challenge in federated learning.
Thank you. Any questions from? Yes, lots of questions from the audience, please.
Right, it's a leftover question from for the federated learning, and then I have just a practical question for digital devices. So my experience with federated learning came more with working with the US FDA Sentinel system, which is claims databases, and what the primary purpose was to do signal detection, safety signal detection, or safety evaluation. And there were quite a few methods that were developed to do, for example, Cox model, that is. So I was wondering, I was surprised that there was no reference to pharmacovigilance in a lot of the federated learning examples, because I feel like whether it's the EU with Darwin, with also Eden, EHDEN, there is a lot of work that is in federated learning, and there is a lot of methodology that was developed to try to answer questions in that way. So I was wondering whether there were lessons learned there that are being exploited sort of in the efficacy and the effectiveness space. For the digital device, it's also real-world data, right? For some things, for some of the at least examples that we saw today, one thing that's learned from real-world data is that there is a very strong day of the week effect, and there is, seasonal trends, or when there is confinement, people don't move, they stay home. So I was wondering how you dealt with these particular kind of challenges in the real-world space. With Floodlight, for instance, you have people repeating the same task. So in that way, it's a little bit can avoid these real-world noise. But on the other hand, there is a learning effect. So anyway, so those are my questions, sorry.
Wow. So let me start. I think in many cases, the examples you mentioned, I think it is an important, I think when we do the analysis, it's much safety data than efficacy. I think there's probably two considerations. One, it's really kind of like the applied methodology. Often is kind of like when you talk about Eden and so on, many publications really is more the meta-analysis. So the power is really to get the data at the hospital standardized, but then basically combine it with meta-analysis. And this works reasonably for some of the metrics like proportion and certain milestones. The second one is also for a lot of, let's call it a little bit more standard safety analysis, you have mathematical closed versions, like a mean, a proportion, and so on. And this you can aggregate in a straightforward way. What more challenging is really these methods where you need this iterative approach and so on. And I haven't seen really many publications in that domain who use really even time to event in the publication.
Well, we can discuss it maybe offline. Yeah, there is, yeah.
But the good thing, I think, probably to the Sentinel program, it really goes into a direction also to think not only on the tools, but also the underlying data, common data models and so on. So I really appreciate we have this different work streams globally ongoing, which really hopefully brings us, in particular with real world data, into some sort of like a closer core data model. So we really can leverage federated learning on basically all the hospitals, and you can just connect hospitals and don't need to actually build up basically the whole ETL or the data pipeline at the site level. Yeah, I don't know if you...
I have nothing to add, yeah.
So I'll take the Floodlight question. So you're completely right. When we started Floodlight, one of the first things we did is give the device to healthy volunteers and ask them to do it twice in the morning, twice in the afternoon for 3 weeks. And then we did the various component analyses to understand where most of the variability was coming from. And the conclusion for Floodlight specifically is that most of the variability is coming from back to back. So when you do it one after the other day, that's where you have most of the variability, which give us the kind of information to say, well, you can just do Floodlight whenever you want. It shouldn't matter in terms of repeatability. In the context of the COVID and the lockdowns that happened, we did an analysis where we showed that just based on Floodlight, we could accurately say when the lockdown started and stopped, simply by looking at how much the people were moving. But at the same time, I do still, or I'm strongly believing that in this context, that's where the digital health technology will have the most power, because in all our clinical trials, what we see is that during COVID, people didn't go to their sites to take the clinical measurements. Well, if they would have had Floodlight, of course, it's not identical to what it was before, for the gait, but we would still have hand, which is one of the domain evaluated by Floodlight, and we would have cognition, which is another domain, which we could have continued to monitor the disease status. But it's very important questions that need to be answered. Seasonality, we didn't look into it yet. You need really long-term data. And then the last one I wanted to say is if you observe a variability across days of the week, which we slightly did, well, we can use then the same approach as what SysNav did, where they aggregate 180 hours of data into a single data point. So we could say we take a whole week of data and transform this into one data point, which is representative of the full week of the patient.
I saw another hand up. Please.
I think you were first. Just go ahead. Yeah, thanks. I have a specific question for Craig Bunk. I know you haven't published the results of the development you told us about yet, but can you tell us at least if you examined if certain modalities are more important than the others? And the background of my question is the paper I read recently in the area of melanoma, where they figured out that I think they were predicting PFS, and they found very small added value when they included histopathological images in addition to clinical structured data. So structured data was most important. Did you generate any such insights? Is genomic more important than radiomics or vice versa, or structured data? Can you tell a little bit about it?
Yeah, sure. That's a very good question. So we definitely have some information on this. We realized that, so what we are doing is using clinical data to build a machine learning model, taking multiple domains, use that as baseline, and then try to evaluate if we now start to add genomics data, imaging data, if we can improve from that baseline. And we also think it's true that in other publications that the amount of improvement is limited. We haven't fully explored that yet, but something we already saw is that using baseline information alone, it doesn't predict, I mean, it depends on the indication itself, right? Depending on which stage the patient's in, if your disease progression time is closer to the baseline, maybe with baseline information alone, you can predict pretty well. But for patients who are healthy, maybe they take 2 years to have the disease progression, then it's harder to predict. But if you add a short time period of data after the baseline, say week 4, week 8, then you can improve that prediction quite a bit, because you are now taking the short interval of how the tumor changes over time.
Thank you.
Thank you very much for this afternoon. I've really enjoyed it. It was great fun. I think that remark was important first from my end. Second part is, when I did a trial with telemonitoring, we had some funny issues. One was when we tried to enroll patients, some of them were not willing to participate in the trial because they said their disease status was so bad that they were not able to really deal with these electronic devices. I think that was one thing. So this was a selection aspect in terms of generalizability. The second thing was that our, let's say, the variables or the time that patients used the variables depended on their disease status. So we had missing data clearly affected by the disease status. And the imputation, and this is, Sheila, what you've nicely described, was getting quite complicated. And of course, the mobility had an impact, social support had a major impact, so there were a lot of these aspects going on. What are your suggestions to overcome these issues? And the final part is some of these bracelets for the ankle don't look comfortable. They look like something different.
Shaila, I don't know, did you manage to hear that?
Unmuting. Yes, I did hear that. I will answer the second question first. You know, the way we can, like I mentioned in my presentation, to collect, we don't know what data to collect to assess, you know, why the data is missing. I think we were in this situation with the missing data before with the other, the regular clinical trial data. So I think for each indication, it may be different, and maybe before when we're designing the trial to understand what questions that we can ask to get more information, if they're more severe, then are we going to have more missingness? That kind of information would be helpful. So to kind of think about that while designing the study to collect more, what kind of information to collect would definitely be useful. I wouldn't know how to answer the question of if severe patients do not want to participate. I don't know at this point how to answer that. What solution for that question?
Maybe,
depends a different device or something, but yeah.
maybe just to, I guess you were going in the direction of missing at random, because I think that was more or less the assumption that Shaila, you had in the presentation. So what happens, because I'm guessing that some of the missingness might have been pretty informative. So have you maybe looked into other alternatives to the missing completely at random that you've had there? If I interpreted well your question, yeah.
Okay, I can quickly answer that. So yes, when I induce the missingness, I use missing at random, but there are other ways of inducing missingness where we can assume missing not at random and redo this analysis, and the thresholds will be completely different. So yes, I have looked at it. But we don't have any information on the missingness itself. So at this point, we can't assume anything more on the available data, on the missing data.
Okay, and I guess the question would be, what are the consequences on the clinical, let's say, results, right? Clinically on the results, if you assume not missing at random.
That work is ongoing. We've not completed.
Great, thank you.
I can maybe also add on, you were asking for suggestions. So what we have implemented in Floodlight is we don't want to exclude anybody. So as soon as they're able to do one test out of the 3 domains, we would include them. And we also enabled that the test can be deactivated by the physician for patients who are not able to do the test. Because the worst thing is that they are reminded every morning that they cannot walk or use their hand. This information also during the study clinical trial can be collected. So the physician can deactivate the test, and then we collect the information of why did the physician deactivate the test. So as in any clinical metric, if the patient cannot walk, we would just impute by a crazy value for the time to event. Then because we collect this information through Floodlight, we could do the same. In terms of, you were also asking different days and things like this, one of the strategy we also thought about is asking the patient to always do the test weekly, but on the same day. You avoid that they have the option of switching from one day to the other. And if they don't do it on the same day, one of the things we could think of is a pop-up message asking like, oh, we noticed that you didn't do it on the same day. Can you say why? Of course, the trade-off is we need to be careful with such pop-up because quickly the patient can have the impression of Big Brother is watching you. And they just kind of stop that. But that's some things that we thought about to try to mitigate and not making any assumptions, but to have the information collected.
I think one of the things we wanted to, just on a side note, what we wanted to do at the beginning of the meeting was take a small poll and ask how many statisticians versus clinicians versus data scientists versus epidemiologists, but the schedule was so tight that we didn't manage. But just along those lines, as a statistician, I'm concerned about all these new data modalities and new frameworks. Do you think that we need a different skill set to approach these topics and these frameworks? Are we missing something here in terms of I don't know, skill sets on the various? It could be platform, it could be IT, it could be negotiation skills, because I think that's a big need also when you're trying to put together a lot of different data sources. So any thoughts on how we should do in the future, and whether or not there will be maybe new roles, new quantitative roles out there?
I think it's probably sure. It's very exciting. Take it on board. I think it's a luxury situation, probably as a data scientist, the decision we are in. We should embark on this journey. As I said, it's challenging, but also very rewarding, big learning. So it's probably in short, yes, a lot to learn, but very interesting stuff. Or to use your words, a lot of fun ahead of us in terms of kind of like all this exciting.
Any deal breakers that absolutely we are in need?
So something I learned, and maybe you had the same learning, when I think about federation, one is really, I think you need to become much more tech savvy. I think things change. I think federated learning has so many different tools. It starts with different programming languages. That's the first start, and all the underlyings, because it's a tech stack. And I think for people, data scientists, statisticians working in this domain, it's really get tech savvy. I think you really need to act much more agnostic across software solutions, database handling. That's probably also the future next to data modalities, because we need to understand the data. We need to know where the data is coming from to do reasonable analysis. But the other thing, I think a big challenge, at least for federation, is really the tech stack, which is very different to probably more traditional analysis.
Yeah, maybe just to add from the data modality perspective, I think the good thing is that even though it's new forms of the data, it's still the data coming from the patients on the drug that we're interested in, on the patient population we're interested in. So by being exposed to this new data modality as a part of the collaboration, maybe other initiatives, you get to know more about the disease itself and how the data was collected, how it's being used in different settings. I think this is something useful in the end for as a statistician to engage in more discussions with clinicians and other interdisciplinary teams.
Anybody want to add anything from the audience maybe on that one? Because I think it's the future, right? Where are we going and what we miss, if we miss anything? No?
I'm gonna just repeat what Dominic has in his slide, which is you cannot do this alone. Just data scientists, in a meeting room are not going to solve all of these. In terms of digital, we have in the room the real guys who are programming the app, who are developing the sensors and all of this. You need to be in collaboration with them. You need to understand the disease. And one thing that I'm going to mention here is, as Dominic was saying, we need also very good tech IT people who have, also some statistical knowledge. I have the pleasure of having Vittorio in my team who can, do on both sides. But we had a couple of challenges, and maybe Vittorio can, talk about this, on just the computational power that we have as a problem. The data are large, the data are getting larger, and R is not great. And I'll stop here. Maybe if Vittorio, you want to add something on this part.
Yeah, so for me, as I come from a computing background, it's much easier for me actually to deal with this problem, and I'm actually trying to compensate on the statistical side. But yeah, so there are some problems that we don't face every day with the clinical data, because the clinical data is actually not high frequency data. It's much easier to work with. We're working very well with R. R gives us a lot of very good tools. But yeah, for example, if you want to deal with time series, the memory management that R does is not sufficient, it's not good enough, and we need to move to Python, to Julia, to something else.
Yeah, thank you. Yeah. I think it's time to thank one last comment,
Sorry,
please.
I just had a very naive question because I don't have a federated learning background. I just wanted some advice about where to start. And this is a leading question because I'm involved in a very old way of learning project, which is about to start next year, where 20 companies are combining all their control data from preclinical safety studies, and we're building a data warehouse. And I want to know whether that is actually the best approach, because there are lots of questions. It's control data, so it's not information involving active compounds. So it's less of a problem if it did have the data that needed to be kept secure. I just wonder if I'm going to go back to this consortium, which is a European fund. Well, we're going for European funding for this, and to go back for a completely different approach to the one that we are about to start on. Well, we will be starting on next September. How should I go about that? What expertise do I need to have involved in this discussion? How do I start? Bearing in mind, I'm a statistician, I support preclinical, non-clinical research. There aren't a lot of data scientists, at least in my company, working within this area. I think what I've seen from federated learning, it's got some real advantages. So how do I start the discussion and start to actually say, is this something we should consider as a different approach?
Very good question. Very interesting problem.
Should I start? I think there's probably a couple of things. One is really what we have seen in the different presentations about the different dimension in federated learning. This really starts, what's the motivation to do it, right? So it starts with the challenges of centralizing data. So definitely call it the legal aspects. Do you want it? It's basically the maintenance. Once you update, you every time need to centrally update versus federated allows to leverage the infrastructure on site. It's also what type of learning you want to do. If you need a lot of computing power, it's also when you say 20 institutions, you leverage infrastructure of 20 institutions rather than centralize everything. So there's a lot of components. Also, what type of analysis you want to do. If it goes really into a little bit, not the machine learning, but in particular federated analytics, depending on the methods, they may or may not yet be there. So there's a lot of considerations, but I think it starts really what you intend to do, how many times what is your data pipeline? So for me, it's more like an end-to-end data pipeline questions, because at the end of the day, if properly incorporated, basically you get very highly similar results. So it's much more the questions about the infrastructure, the legal considerations, and only then I would go a little bit more into what technical solutions fits everything. The other one is probably also the type of data, but you mentioned it sounds more like clinical trial data, control, so data model, all those items are really to be discussed. It applies in both federated and centralization, but I think it's really a lot of different dimensions. It's hard to say you start with this topic, but it sounds a little bit more like, are people willing to share? Do you see, and from my experience, this was really like, we discussed with many hospitals, and I think there was certain hesitation to go centralized too big, because then they control everything. Everybody felt like, can you really have a full valid governance, right? What happens with the data longer term versus federated allows you much more module-wise approach to this, to really maintain also a little bit what you do with the data, measure it more properly, what's the contribution of your specific data set. So that's probably more also the willingness to grow if people participate more, if you offer like federated or these alternative approaches. That's for me more probably where I would start.
It pains me to put a stop to this conversation with a very interesting question, but I think it should come to a close. So one last applause, please. Thank you to everyone, also everyone online. Shaila, thank you. And I think
please stay for the assembly if you have time.
And also online if you wish.
Online as well.
Yeah.